Okay, the scapula we're going to pick up on page 260. We're looking at the AP projection. The AP projection, it tells you it's a 10 by 12 lengthwise. Patient is in an upright or supine. The upright position is usually more comfortable. You've heard that as a common thread through everything, right? Anytime a person has only shoulder injury, only pain or discomfort with the shoulder, it's best for them to stand up. But what happens, my thought is, you've come in and it's an MVA, motor vehicle accident, they're hurting over their shoulder, probably going to have other injuries, probably going to be on a backboard. So you standing these patients up, is it going to happen? No. So you have to keep that in mind. You have to work with what the patient presents. Okay, under position of patient, it says place the patient in the upright or supine. I read that. Position of part, it says the second bullet, abduct the arm at a right angle with the body to draw the scapula laterally. And that's what this little lady here is doing. She's abducting the arm, and by abducting the arm, it pulls your scapula laterally. You're trying to pull it off of the what? Thorax. Okay, so it's the how. So we always say how. And here it's being done erect, or you can do it supine. It says, for this projection, do not rotate the body towards the affected size because the resulting obliquity would offset the drawing of the scapula laterally. So you want the patient to be flat. You don't want them to favor one rotation or the other. We don't want them to rotate towards the affected shoulder, nor do we want them to rotate away from the affected shoulder. Just get them to stand up perfectly straight and take it as is. All right, position the top of the IR 2 inches above the top of the shoulder. Now, look at respiration. I'm on page 260. I guess I can bring your 1 through 9s that Dr. Curtis put in there. It says, make the expiration during slow breathing to do what? What's obliterate mean? It's in your book. Under respiration, have the patient make the exposure during slow breathing to obliterate.
To get rid of.
What's that?
To get rid of.
Get rid of, to obliterate. Yeah, you can say get rid of. It's actually to blur them out, to obliterate them so they're no longer visible on our image. Okay. So it says slow breathing. This is not a breathing technique like we're going to be talking about for that transthoracic where you adjust your exposure variables. This is just having the patient breathe slowly. And that's going to obliterate all of your lung detail, all your markings, and hopefully you will get a good picture like this image here. Can everybody see the medial border? That light line right there? That's the whole scapula. And the only reason we were able to do that is because this blurred out some. And then the white cortical line of the medial border is showing up. Okay, remember I told you how important respiration was going to become, or breathing instructions? Here it is. So for your lab test now, you're going to, if you draw this one, AP scapula, you're going to have to tell me, first of all, why are you doing your arm abducting at 90 degrees? It does what? Pull the scapula laterally to the side off of the thorax. And also to improve the picture, we're going to have the patient to breathe slowly, breathing during the exposure to obliterate the lung markings. All right, any questions on that? The central ray is going to be perpendicular. Mid-scapular area at a point approximately 2 inches inferior to the coracoid process. So here's my little red line, my little dot here. Here's the coracoid, and we're going to go down about 2 inches. The shoulder was a what? 1 inch inferior from the coracoid. Now the scapula is 2. So don't make this hard. You want to get the shoulder, you're 1 inch inferior from the coracoid. The scapula, you know it's longer, so you're going to have to go down lower. So now they're saying 2 inches below the coracoid so that you get the entire, the lower angle of the scapula, and that's it right here. Everybody see that? Entire scapula with the lateral portion free of superimposition from the ribs, scapula horizontal and not slanted. This is pretty good looking here. Any questions on this? Supine or erect. It's a 10 by 12, 10 by 12 lengthwise. I would say you want it because it's a long triangular bone, so you're going to want to include it all. I think I got a better picture of one. Yeah, here's another one. There's your inferior angle right there. You can see the real pretty white line of the medial border. Here's your coracoid. Here's your acromion. AC joints right there. There's your glenoid cavity. You see how it's kind of turned up right there with the humeral head in it. This is your lateral border. It's the much thicker border. And the respiration was what? Slow breathing to obliterate lung details, lung markings. And the central ray was where? 2 inches inferior from the coracoid. Yes, it's a pretty good looking one there. What's this little black space right here called? AC joint. Very good. All right. And this is just another view of it. It's more anatomy. I think everybody got it. Everybody knows it. Obviously, you need to know the coracoid. It's the finger-like projection. It's always that white, bright area on the scapula or on the chest. The acromion actually wraps over the top of the shoulder and wraps back around to articulate with the clavicle. We do have a superior angle. That becomes important when we talk about the clavicle. We have the inferior angle. And again, you can see how thick this border here is. This is going to be your lateral border versus the very thin vertebral border. And this is the back side of it. You have a crest, again, the acromion, the infraspinous fossa. Don't really need to know this. It's just another picture of it from a posterior view. We've already talked about the 3 borders. Everybody sees the 3 borders here. Again, this is your lateral border. This is your medial. There's your little coracoid. There's your AC joint. Here's your acromion, humeral head, glenoid cavity. Anything on here I have a question about? All right, let me show you. This is the graphic. This is what we're after. Okay, so this is the central ray, and we're shooting this patient from the back, right? Look what we've done. We've taken that scapula, which is at an angle. When you get in lab today, you'll notice that they're already at an oblique. We're going to turn them until our 2 borders get perpendicular in our hand. And that's what it's showing here. You're going to be entering the medial and coming out of the lateral borders. You want that body of the scapula to be up as perpendicular as you can. Okay? And this is the AP. Central ray is coming. It's the same concept. But look, this side is rowed up for the AP. This side is rowed down. Because here's your image receptors here. Okay? So if you're going to do it PA, you're going to do side down. If you're going to do it AP, you're going to roll the side up. And like, can't think. OID. You see the inherent OID right here? So that's obviously going to do what? Cause a sense of magnification of this. Any questions? All right. Let's see. So looking at this one, Miss Francis, looking at this one, what do you think about it? Do you think it meets criteria? It's a scapula Y. I have a problem with this. This is the vertebral border, the thin one. This is the thick one. Can you see that they're not completely superimposed? Because you can still see part of the body of the scapula, right? So for us to have gotten this thicker border, she's what? Over-rotated. So we've rotated her so much that the border that was on the outside is now next to the what? Thorax. So you'll be able to like determine, looking at one, which way you need to go, if you need to go to get it repeated. And to be honest with you, for a shoulder dislocation, a department would probably pass this, because we're not looking at the what? We're not looking at the scapula. It's not an exam of the scapula. We're interested in where is the humeral head to the what? Glenoid cavity. But if you're a perfectionist and you wanted to go in there and try it again, now you would know if that thicker border is next to the thorax, we need to decrease that. That's too much rotation. Okay? Because our objective is to get these two borders here superimposed so that they look like one. Okay? You got it? Any questions? All right. This is the lateral scapula. All right. This is Dr. Curtis's 1 through 9. And let's see. We're going to go into page 262. Y'all have your 1 through 9s? All right. Page 262, it says again, starting with patient. Position of patient: upright position, standing or seated, facing a vertical grid. The prone position can be used, but the projection is much more difficult. Yes, it is. Okay, and this is not for scapula, Y for shoulder. This is for scapula now. Okay, now we're we got an exam for a patient's scapula, not the shoulder. We've left the shoulder away. Okay, it says adjust the patient in an RAO, LAO position with the affected scapula centered to the grid. Very, very similar to what we just talked about. Looks just like the same picture, doesn't it? Remember, if you're doing it PA, it's a side down. Okay. Same type of rotation, 45 to 60. Isn't that what the other one said? Okay. It says, according to Johnson, proper patient rotation is accomplished by orienting the plane through the superior angle of the scapula and a acromial tip perpendicular to the IR. Okay, and it says, for delineation of the acromion and coracoid process of the scapula, the patient comes in and I say, where are you hurting at? And they're saying, I'm hurting up here at the top of my shoulder. Usually where a seatbelt will be, right? Okay, so in order for us to get that cleared of the humerus, we have to put the arm behind us. So we're going to hide the humerus and we're going to bring it down. Okay, so you see what we've got here? The position of the arm becomes what? Critical when you're doing a scapula. It wasn't critical when we were doing scapula Y for shoulder joint. We didn't care. Okay, and here we do. So when the arm is pulled back like that, that is going to clear the two processes at the top. Okay, so we've got the arm flex behind the thorax. That's clearing this up here. Let me go back. I want to share myself one. All right, so what I'm talking about here is patient comes in, they're hurting here, right? These are your processes. This wouldn't make sense, would it? Because I've just brought the arm and put it over the processes. This makes sense. Now the humerus is out of the way and the processes are cleared, right? So in our history, we have to ask, where are you hurting at on your scapula? So we know what we're doing. Are we doing it for the processes or are we doing it for the body? If we're doing it for the body, put the arm over the processes and shoot just the body. So you're going to have two arm movements. And that's the trick on image critique. You're going to look and see, where is the arm? Is the arm directly over this way? That tells me it was a scapula done for what? The body. If my arm is like this, It's done for the processes. Do y'all see how it's similar to the scapula Y, but the placement of the arm for the shoulder dislocation scapula Y, it said put the arm wherever you want to put it. We're just interested in the relationship of the humeral head to the glenoid cavity. Now here it's telling us we have to be aware of what part of the scapula we need to demonstrate on the image and get the arm out of the way. So that's going to be a real good trick for on image evaluation, your image critique test. Look and say, okay, well, the humerus is directly over the body. So that must be a scapula Y4 shoulder joint, right? Because remember, it would be this, but when it comes out and it's just like this, and you got the two borders and the humerus all superimposed, that's looking at the glenoid cavity and the humeral head for shoulder joint dislocation. But when you get one like this, the arm is like this, cleared the body. So this is scapula for the body. This is for the processes. Takes a little used to talking and thinking about it, but all right. Let me share my screen again. All right, so let's look at this. Lateral scapula with the arm on the posterior chest. So that we have got this arm, we got this like this, right? And they're saying that you could, you're putting it down here. So what is it used for? The processes. So this middle one, you got the arm, you see where the humeral head is at? And it's pulled over across the top with the clavicle. So what is it used for? The body, that's right. And this is just another way you can do it. You can actually bring the arm straight up above the head instead of across the upper thorax, as long as it's not superimposing any part of the body. But do you get what we're going with this? If that humeral head is covering the body, then it must be for the processes. If it's covering the process, it must be for the body. Everybody understand that? All right. I'm trying to think. This is all on page 263 also, if you want to correlate a page with it. All right. On page 264, 265, this is where I was telling you earlier on that one page where it had that little paragraph with the scapula Y for shoulder joint. It said you can do it AP. This is the same thing they're telling you here. You can do what we just looked at as far as doing them erect. You can do them on the table. But it's all about the what? It's all about the arm placement. Okay? All right. So just be aware, and honestly, you'll get good at doing them AP because, again, if a patient comes on a moving board, a trauma board, you're not going to have an option of flipping me over. If I'm all crushed up and I say, oh my God, no, I got to do UPA because that's the only way I know how to do them. No, you'll learn how to do them AP. And luckily at our facility, that's all they do them is AP. Even with the shoulders, all of our shoulders are done on the table with the scapula Y for shoulder dislocation, all on the table. So you'll get very good at it. But always remember, if you can do something AP, you can also do it what? PA, dictated by the patient condition. All right. Clavicle. Should I stop it there and start another video over just the clavicle? All right. Stop.